Hello, my name is Heather Sheline. I'm going to be presenting a pediatric case study on bulimia. Bulimia falls under a category of eating disorders that affect about 5% of the population. Other eating disorder types are anorexia nervosa, avoidant restrictive food intake disorder, or ARFID, binge eating disorder, pica, rumination, and restrictive foods. Bulimia nervosa is categorized by a pattern of overeating, referred to as binge eating. This is followed by some compensatory behaviors such as purging, fasting, laxative use, or diuretic use. Sometimes excessive exercise is utilized to prevent weight gain. This is just, they kind of refer to this as a total loss of control in their choice to eat all of this food. They just keep eating and eating and eating, and it's not, they don't have any control over it. And then they do these other behaviors to kind of get rid of all those extra calories. It's usually secondary to body image concerns. Their happiness depends on the way that they look, and they feel like they don't look the way that they should, and they have these behaviors to try to lose weight. Primary care providers play a vital role in early detection. It's so important that we're screening and have our eyes open, watching for any behaviors or any clues that these children might have an eating disorder, or adults. More often affects females, 8 to 1. Typical onset is late to mid to late adolescence. They're usually in normal weight range. Anorexia, on the other hand, they're usually underweight, under normal BMI. Diagnosis criteria is that they binge and purge at least once a week for longer than 3 months. They usually, I already discussed that, have anguish over binge eating behaviors and often report it as feeling out of control. This case study is on a 15-year-old female, CC. She presents to the Peds office due to parental concerns. Her mother states CC has been withdrawn from family and friend group, excessively using the home treadmill, had recent weight loss despite eating large amounts of food while parents are at work, and often skips family meals or will only eat low-calorie meals. Mom does confide she suspects an obsession with weight loss and body image. Subjective info collected from mother and patient. The current illness, she fainted yesterday at basketball practice. She has concerning weight loss of around 25 pounds in the last year. Ongoing fatigue, mood swings, withdrawn, poor appetite, generally has also consumed large amounts of food on occasion, so much that she feels sick afterwards and has gotten sick or had possible stomach virus per mom. Last episode, ate only low-calorie items at Thanksgiving meal, but late that evening compulsively ate a large amount of leftovers, felt sick, and admitted to self-inducing her vomiting. CC states she restricts meals due to the desire to lose weight, but then loses willpower to stop eating at times. Reports an intake of water, boiled eggs, and a plain rice cake today. She ran 5 miles on the treadmill this morning and plans to run this evening again. Allergies, medical, surgical history, mild seasonal allergies, tonsils and adenoids out at the age of 4. Vaccinations are up to date. Medications, Zyrtec and orthotricycline and PRN ibuprofen. Family and social history. CC competes in beauty pageants since the age of 5, recently joined the school basketball team, and peer relationships are strained. She states comments have been made about her weight from basketball coaches, teammates alike, but never from pageant peers. On birth control to regulate her periods and acne, denies being sexually active, supportive parents, and 1 older sister. Review of symptoms, she's tired, has frequent nausea, occasional dizziness, sore throat, occasional muscle cramps. Last menstrual period was November 23rd. Periods are light, 3 to 4 days. She does state difficulty focusing on schoolwork. Daily run walk goal of 12 miles. Her 24-hour diet recall includes small amounts of low-calorie foods. Objective data seen in this office for annual well child since infancy. Unremarkable findings at past visits. Overall weight is down 26 pounds since last well child exam 10 months ago. She's dressed appropriately, is clean, and well-kept appearance as always. Vital signs are stable. She has mild throat pain, 2 out of 10. Weight is 120, height 5'6". Skin is warm, dry, pale. Throat excoriation without exudate. Teeth are intact. Braces are present. Heart tones are strong and regular. She has peripheral vascular, no abnormalities, There's no edema, no palpitations of the chest or chest pain. Lungs are clear. Respiratory rate is regular. She denies any cough or shortness of breath. Her belly, upper abdomen muscles are a little bit tender to palpation. Bowel sounds are normal. Denies any constipation or diarrhea. Belly is soft and non-distended. She's alert and oriented, no deficits noted. Answers are somewhat guarded. She verbalized embarrassment over overeating patterns, but feels unable to control them. Some differential diagnosis here and some rule-out criteria along with these diagnoses. The norovirus, this is probably unlikely since she's had intermittent vomiting and diarrhea for at least 3 or more months. This is not just a 4-day virus or less, it's longer. Diabetes, blood glucose is found to be normal, and A1C was normal on lab work. POTS, orthostatic blood pressure was found to be normal. Anorexia nervosa can also have binge purge component, but anorexia BMI will typically be below normal. Purging, laxatives requested for constipation, excessive treadmill use have been things she's been doing. Substance use could be possible. Co-diagnosis, we'll rule this out with a urine tox screen. Depression and anxiety are also possible co-diagnosis and will be evaluated more through emergency psych planned for today. Bulimia nervosa is the most likely diagnosis based on the assessment data, and all diagnosis criteria are present. The treatment plan for CC, first we need to determine if there's a major emergency here. We're seeing her in the family practice office. Do we need to send her to the emergency room? Does she need to go? Is she suicidal? What's going on here? So first determine that. In this case, labs are coming back normal. Vital signs are stable. Patient also denies thoughts of self-harm or suicide, but long-term eating disorders have a high rate of morbidity. So this diagnosis always requires immediate and multidisciplinary care. Per parental consent, Northeastern Center counselor emergency evaluator is en route for an emergency evaluation. Our office contracts with them to come in and see any patients that we have concerns with. This will result in quick treatment options which are needed in this situation. We will be encouraging parent to communicate with the school counselor, nurse, and of course our basketball coach regarding the best plan for return to school sports and academics. We would follow up with primary care in 1 week, have her follow up with us in 1 week or earlier if there are any emergent needs. Treatments can include Prozac, has shown to be effective for bulimia behaviors, a dietitian follow-up, and routine counseling specific to bulimia. The diagnostics and interventions that we would like to have in place before she leaves the office today, it's priority to first ensure medical stability so mental health evaluations can occur timely. Lab tests, CBC, electrolytes, total protein, evaluate her liver, thyroid, and kidney for functioning. Screen for vitamin and mineral deficiencies such as iron, vitamin D, B12. We're going to obtain an EKG to ensure dehydration, electrolyte imbalances, or thyroid issues have not caused any cardiac dysrhythmias. Mental health evaluation, and hopefully in this case intense inpatient center care. referrals to specialized dietitian, eating disorder support groups, and family-based treatment. Although her family is supportive, this really requires special care on discharge from a facility, and family needs to be ready to meet her needs, and they're going to need a little bit of training to do that. Some community resources and support groups include the Northeastern Center, which is coming to evaluate CC today, coordinate care with school nurse, athletic trainer, and school-based counseling services can also be utilized. The Emily program is an online resource for eating disorder assessments. Treatment options are virtual, residential, and outpatient. They also have day treatment options in their facilities in Cleveland and Columbus. This is an online one, the National Alliance for Eating Disorders. They have free virtual support groups for eating disorders. Separate groups also for family and friends, which I mentioned before. It's very important to get them involved because that is her support group and they need to be prepared. National Eating Disorders Association for online screening tools, guidance, and treatment finder is a great resource as well.